his thing, it's not time to say goodbye yet?
Yeah, somebody told me about that. I didn't see it, but they...
Maybe some of you, although most of you know him. I think some of the best gerontologically based salivary research in the country is done right here in his lab and with his lab leading collaborators, including myself on some occasions. So I'm very interested in having him recount to you some of the research efforts that do go on here and how they relate to maybe some of the clinical practice that you're involved with. Thanks, Chih-Ko.
Thank you. My original assignment is oral health and aging research update. So it's all over my head, so I cannot cover all these things. I have done salivary gland research, saliva research in the past 20 years. So I decided to focus the talk to my own, the research close to myself, and also to discuss a little bit about why this salivary gland research is important. What does that mean to the geriatric patient cares? So three objectives for this presentation. First, we're talking a little bit about the physiology of saliva, especially talking about the effect of aging on salivary flow rates. Then we give a very brief discussion on the salivary gland disease, which are not many. Okay, luckily we don't have many salivary gland disease, but if there's a salivary gland disease, usually it's age-related. And we are talking a little bit about the clinical diagnosis and the management. Focus on the management because there's no treatment for salivary gland disease so far. So we only can say we can manage, but we don't know how to treat. Salivary gland research, I give an update. There are some very exciting development in the past 7 to 5 years that maybe have a impact on geriatric healthcare. First, the catchword is saliva is your friend. Okay. Saliva just like water, air. When you have it, you never miss it. You know, you feel so natural. You never think about it. But if you don't have it, the quality of life really suffers. Also, saliva is fountain of youth because in saliva we have a lot of growth factor. Okay, the experiment they did is if you cut off the saliva, the animal developed peptic ulcer because they lost all the nerve growth factor, they lost all the epidermal growth factor. So also saliva is a fountain of youth. The function of saliva is multifunctional. Okay, the lubrication, you know, if you think about it, if there's no saliva, moist your oral mucosa or cover your teeth are going to stick with your oral mucosa. You cannot talk, you cannot swallow, you cannot taste anything. So lubrication is very important. Digestion, saliva contains a lot of proteinase, amylase, DNAase, RNAase, and when you're chewing, you put all this enzyme into your food bowl. Okay, then you swallow it into your stomach, so you can digest from inside out, also outside in. So it's more efficient. If you don't have saliva, your digestive system is going to suffer. The most importantly, saliva is a host defense mechanism for oral cavity. Okay, you know we always say animal lick their wound, right? If they got fight, they got hurt, they always lick their wound with saliva. That's for purpose because saliva has a lot of antimicrobial proteins there. Okay, if you don't have these antimicrobial proteins there, the oral cavity is going to be infected all the time. Also, saliva is very unique solution. You know, they are hypersaturated with calcium phosphate. So the teeth basically is calcium phosphate structure. So if you don't have a supersaturated calcium phosphate there, the teeth is going to melt out. Okay. So without saliva, the oral soft tissue and the hard tissue cannot maintain their healthy function at all. The lastly, saliva is a body fluid, can be used as a diagnostic tool. Okay, we are going to discuss a little bit more. You know, in the medical arena, people use blood, use urine to do all this testing, but maybe people say the culture, spit is really terrible. Nobody really want to use the saliva, but I will show you some features. It's really exciting for the future. In human, we have three major salivary glands, three pairs major salivary glands, namely parotid, submandibular, and sublingual saliva. Then gland. Then we have numerous minor salivary glands surrounding our oral cavity, so we can keep our mouth moisture. There are several unique features of these major glands and the minor salivary gland, which is very useful for the medical treatment. Actually, the first, all these major glands well encapsulated by the fibrous tissue. So one imagination is you can, if you want to do the gene therapy, you can retrograde. You can retrograde inject into the gland. So you can put the gene or infect the gene to this gland tissue, and without spread the gene or DNA, RNA all over the body. So that's one very unique tissue. Also, those salivary glands count as exocranial gland. But the data again can show they also have an endocrine gland features there. So in the future, you can use this gland to deliver hormones, deliver therapeutic medications to the patient. So this is two features. It's not well known, but it's exciting feature of the salivary gland tissue. If you look at the microscopically, the salivary basically have two components. One is arsenite. Depends on the cell type. The gland types, they have different kind of arsenite cells there. They produce different components of saliva. Then they go through a ductal system to they look at the ductal system to modify the saliva. So we always say there's a two-stage secretion of saliva. When saliva comes to the mouth, it's hypotonic solution. Okay, that's another mechanism to defend the bacteria. So basically, you have a ductal acinar cells and ductal system, and these cells controlled by the sympathetic nerve and the parasympathetic nerve. Okay, in our body, again, that's another unique feature for salivary gland. In the body, you always have a sympathetic nerve doing something, parasympathetic doing other thing, sort of like antagonist. But in saliva, both parasympathetic and the sympathetic nerve stimulate saliva flow. Okay, but they stimulate different kind of saliva. Okay, the parasympathetic stimulate more fluid saliva, and sympathetic nerve stimulate more proteinous saliva. So that's another unique situation. Some factors is going to affect salivary flow rates. Certainly, if you dehydrate, you'll feel dry. Also, there's circadian and seasonal changes with saliva flow rate. Like right now is the high point of your saliva secretion. When you go to sleep at the night, there's no salivary flow rate at all. Okay, so that's why we always tell people brush at least twice a day, right? Once before you go to bed and after you get up, right? That's a major reason, because during your sleep there's no saliva flow rate. If you don't have saliva flow, there's no cleaning mechanism in your oral cavity. Okay, so the bacteria just going to accumulate. Okay, so everything we recommend have a reason. The gender differences, just like a bone or other tissue, seems male always better than female, but come to the end, probably it's equal. When we're young, the male secrete more saliva. We are going to talk about aging a little bit more, and also body size, psychological factor. If you're stressed, your anxiety, you always feel most dry. You know, if you look at all these politicians give a talk, they always have a glass of water next to them, right? The more water they drink during the talk, during the speech, it means they're more nervous.
Better pointer. You just press there.
Okay. This is better. So certainly the disease and the medication we're going to talk about, we're going to affect salivary flow rates. Right. Next few slides we discuss, what is do saliva secretion decrease with age? That's a big question. Yeah, before 1980, everybody assumed salivary secretion decreased with age. Nobody questioned. Then come to 1980s, there's my boss, my mentor at NIH, participated body more longitudinal study. They studied the participants in BLSA population. They didn't find any changes across age group. Okay, so in 1990s, our institute get funding from NIDCR, one sub-project to give us the chance to look at the oral health San Antonio longitudinal study. Acronym is SOSA. Okay, there's other studies. In general, throughout the aging, you can see the acinar cells or the secretory component we call decrease with age at the microscopic level. They're replaced by adipose cells, adipose tissue or other connective tissues. Okay, so we know that at the morphological microscopic side, the secretory component of salivary gland decrease with age. But whether the function is really decreased with age is a question. Like I said, in 1980s, body more longitudinal studies show there's no age effect on salivary flow rates. So even until now, people still think that way. But when we studied community-based population, we find people, we found across there's age effect. Okay, generally they decrease salivary flow with age as people aging. So not only people with medication, even people without medication, so-called healthy aging people also decreased. So we also find that our the salivary composition is changed also during aging. Okay, so not just flow rate, also composition changes. So we did what's happened there?
Either hit escape or okay.
So we did the meta-analysis. Sorry, I forgot to mention the old source of the PI is Dr. Michelle Saunders. So we did collaborate for more than 10 years now, right? Then we did a meta-analysis. We take all the data from the literature, and John Cornell helped us to do the analysis. So you can see there's a decrease with salivary flow rate with meta-analysis. What does that mean? People always argue. You see this trend there. Really, is that going to cause disease or problem there? The argument, some people say this decrease doesn't count, but realize in the elderly patient, if they have a lower background flow rate, then on top of that you put more stress there. They have to take medication, other things there. Certainly, you will see more people complain of dry mouth in the elderly people. So I think that right now the consensus is at the general population there is so-called normal aging. There is a decrease in unstimulated saliva or resting saliva with age. Okay, certainly in the society you have a group of people is really have a successful aging. Such as a body more longitudinal study cohort. They are all physicians or physician's friend or spouse. So it's totally different patient cohort there. Also the reserve capacity decrease with age. Okay, what does that mean is if you stimulate a person, young and old, long enough, you will see the differences. The reserve capacity decrease in the saliva is decreased with aging. So that's the take home. Clinically, we use a dry mouth. We always say people complain dry mouth. Actually, dry mouth xerostomia is subjective complaint of mouth dryness. Okay, whether this is real salivary gland hypofunctioning or not, for salivary gland research, we are not sure. Sometimes we see patients complain of dry mouth. You measure their flow rate compared to other people at the same age group. It seems they're fine. So the question comes to here: how much saliva is enough saliva? Why somebody have same amount saliva as the next person, but one person complained of dry mouth, the other person has no complaints at all. So this is still a dilemma. Okay, nobody really knows. As a researcher, we always artificial cut off one number. Okay, the magic number right now is 0.1 ml per minute. You know, if your salivary flow rate lower than 0.1 ml per minute, you have a dry mouth. Okay, that's a, don't ask me, somebody set up in the literature that everybody quoted. So that's not evidence-based information. But again, the message I try to convey here is when we talk about xerostomia, dry mouth, not necessarily the patient has a hypofunctioning, but there are several. So there are several factors that can cause xerostomia or mouth dryness. Most of this situation happen in the elderly people. The first is there are three major conditions can cause xerostomia. One is drug therapy. If you look at PDR, there's more than 400 medications can cause mouth dryness. Okay, but again, it's a subjective complaints. Nobody really document there's a lower flow rate. It turns out it's very difficult to document individual drugs affect the salivary flow rate. The overall consensus is people did a study show if you take more medications, you're going to have a more chance to get a dry mouth. Okay, the number of the medications is more important than the type of the medications at this moment. We feel radiation therapy to the head and neck area to treat the head and neck cancer. That is sometimes become a limiting factor for oncology to treat patient because patient feels so dry or desperate, so they cannot give a more dose of irradiation. So that's another problem for salivary gland tissue. That's why oncologists always are interested to our salivary gland research because even they can cure the head and the cancer, but the quality of life is terrible because of all the glands destroyed during this treatment. The third major reason is so-called Sjogren's syndrome. Sjogren's syndrome is dry mouth syndrome, and it's autoimmune syndrome. That's our three major problem with salivary gland disease. And we also showed other diseases like diabetes, HIV infection, and also can cause mouth dryness. So again, if you don't have enough saliva in your mouth, you'll see, the fissure of the tongue, dryness, little bit of infection. Sometimes you have a candida infection there. The rotten teeth is a hallmark of the lack of saliva. So I show this is the lesson I tell you later. I showed this is in 2003. The issue is published by the UTHSCSA Center. Did a feature on our research. So they asked us, this is one patient. They interviewed one of our patients with a Sjogren's syndrome. So this is exactly from the patient's mouth. The wording, it's like trying to eat with a mouth full of sand. Okay, that's their life quality. Every day they feel that way. So some patients without saliva, really suicidal. You know, they really feel bad about it. I sort of put gene therapy there because this is a future study. But look, first I didn't know how many people really read missions. Okay, the turns out all over the world read missions. After this, the article published, I received several of the email from all over the world to ask me. This is one of them. Is a retired Navy captain asked me. You know, he had surgery radiation on their on the tongue. Then there's no saliva. You know, he really interested in gene therapy. So I showed this lesson is don't open. You know, your mouth. You think it's unimportant. Somebody is going to come back to get you. Number two is the salivary research really is important for certain people. You know, people really devastating to looking for the cure, treatment of salivary gland disease because the quality of life is really horrible. Actually, you know, there are several questions we can ask patients. All these questions have really correlate well with clinical reduced salivary flow rates. Okay, not just if patients say yes, one or two of these questions, probably this is a good screening. You don't have to ask all these 8 questions. You probably ask 4 is enough or 2 is enough if the answer is yes. That's a good screening to tell you whether the patient really have a dry mouth or not, or low salivary flow rate or not. So you can go a step further, but I don't think anybody doing this except our salivary gland research. Here I just want to tell you, you know, we for salivary gland research, we collect different kinds of saliva. You know, you have a whole saliva, you have a individual glandular saliva, and also you have an unstimulated and stimulated saliva. So we have different kinds of saliva. The reason I want to present to this to you is to let you know the saliva you have different meanings. Okay, if you want your saliva as your research tool or research fluid, come to talk with us. You know how to collect saliva, what kind of saliva you need, and what does that mean. Okay, that's very important. You know, if you collect saliva, one patient in the morning, the other patient in the afternoon, the data come out probably is useless. You know, you have to, because there are circadian problem there, so you have to collect saliva in a certain time of the day. So we have all different kinds of tools to collect saliva, different methods to collect whole saliva. This is how beautiful, you know, the saliva is come from the parotid glands, clear, just like you know, it's not like whole saliva. You know, some sides look bloody and muddy, but the pure saliva is supposed to be sterile and very clean saliva. This is how we collect some mandibular sublingual saliva. How do we manage a dry mouth? So you can use saliva substitute, artificial saliva. You can give a systemic saliva stimulator. We're going to discuss a little bit more. Then you know you have to realize the patient needs more caries prevention. Probably you send the patient to a consultation to a dentist to have a fluoride treatment or dietary counseling. You know, the patient already dry. You're not supposed to drink a lot of coffee or alcohol. Make because drier. So the dietary counseling to reduce sugar because they lost the cleaning, self-cleaning system in their mouth. So that dietary counseling is important. Prevent candida and oral infection, other oral infections is also important. I put different color there. Gene therapy and tissue engineering is the future, and there is some progress, but probably we have to wait another 20 years to see the possibility. Saliva substitute, artificial saliva is a lot of commercial product on the market, but to realize saliva is such a complicated solution. The artificial saliva only give you 1 or 2 components of salivary component. They only can relieve the symptom, but not necessarily have a protective role. not necessarily protective for your teeth or for your oral mucosa. Okay, and the advertisement always say, they always say, well, it only cost patient 50 cents a day, $1 a day. But add up, there's a long-term use. It's not used 1 or 2 days. Use $365 a day. So it add up is a lot of money. Also to realize, read the label of these things. Certain, at least 1 or 2 of these artificial saliva, the pH is really low. Okay, if you have a low pH, you're melting all the teeth. You not only protect the oral cavity, you try to to melting all the teeth. So what we do, we usually ask patients to carry a squeeze bottle with a plain water. If you feel dry, you just squeeze around, so you don't have to go to the bathroom too often. Also, it's not going to melt out your teeth. So that's what we usually suggest patients to do. Another treatment is use parasympathetic mimetics. Use pilocarpine and Evosac. These two are commonly used for the salivary gland dryness, but there's no long-term study yet. Okay, for the short term, people can relieve symptoms, but what is the long-term effect, we don't know yet. And also like pilocarpine, if you look at the literature, they say you have to use up to 12 weeks, more than 12 weeks, in order to see the result. I probably can tell you why. Okay. That's part of our research to show you probably why at the end of this presentation. Some saliva research updates. The first, over the past 7 years, NIDCR, NIH really pushed to use saliva as diagnostics tool. Okay. What they did 2 steps. One step, they gave out large funding to develop technology for saliva oral fluid-based diagnostics. Okay, we are being involved in this sub-project right now with Austin Group. One thing is this particular disease in our group is look at the cardiovascular disease. Another approach for NIH is to push it for salivary proteomics. Try to have a catalog of salivary secretory proteins. So far, they already identified more than 1,400 proteins in saliva. Okay, so this one step is to try to have a new biomarker discovery. They hope they can have a new biomarker discovery through this process. So there are 2 efforts there in the past 7 years. Really try to push through. I put there, one friend called me the other day, say, well, in Wrigley, the chewing gum company, told me there's a group of people, the chewing gums, the gum dissolved in their oral cavity. I never heard about it. So their immediate response say, what's wrong with their saliva? So they want us to do a little bit of study. We spent a year to write up the contract, but I haven't seen any sample yet. So that's a different experience deal with industry. The use saliva as diagnosis tool is not something new. It's already used in the clinic, like the HIV testing. Right now, you really can use oral fluid. In 20 minutes, you can tell whether the patient was HIV positive or not. As you know, last year, the CDC changed the recommendation. Before you test somebody for HIV, you need informed consent. Right now, you still inform patient you're going to test HIV, but you don't need their informed consent anymore. You need their specific statement say they don't want to be tested for the HIV. So it's totally different practice right now. So CDC also tried to push for this oral fluid diagnosis as a screening tool. It's not as a definite diagnosis. As a screening tool, a definite diagnosis still need blood testing. Okay. But again, use oral fluid or saliva to make diagnosis. It's not something new. People use saliva cortisol to study the stress level, to psychological problems. Is well documented in the literature, and also law enforcement has a really incentive to study using saliva to detect drugs, to detect alcohol levels. I was told, the saliva is a better body fluid to detect alcohol levels than using blood. There's a reason for that. So there's really an industrial push there to develop saliva-based diagnosis tool. This is a study I involved. Again, this is a so-called UO1. It's a contract kind of a study. It's different from the regular NHR1 or PO1 or program or project. So we work with a group of people organized by the NIH. So like a moving target, you change your target every week. We spend the time to write all the IRB, get approved, and next month they come back say, I want you to do the different things. We have to write the IRB again. So this is a kind of experience, but this is a huge group of research funded by the NIH. Also, this group also funded by the Gates Foundation. They developed a lot of oral diagnosis. Not use the microfluidic diagnosis for the HIV/AIDS research. So this is the idea, the exciting idea NIH pushed for. So we use a nanotechnology. Okay, you develop the nanopore beads. These so-called microreactor. You have a small beads with a lot of pores, so they can hold a lot of analytes, whatever you want to detect, the proteins or DNAs, RNAs. These beads has tremendous surface. They allow you to detect the different material analytes. So also they develop, because we believe there's no single biomarker for any single disease. So right now, the consensus, you probably have a panel of biomarkers. So the device design is not to try to analyze one analyte or one component. So the design is multiplex platform. You want simultaneously analyze 7, 8, even to 100 analytes simultaneously. Use 100 microliter, whatever, the blood or saliva or body fluid. That's all this technology. Okay, is already exist. It's not something new. Then they have to compact into these nano biochips. That's why they call it chips. Lab on a chip. Okay, so you put your sample there. This is about the credit card size. Okay, just like a credit card size. So you put your sample there. It goes through this process. You gather your result there. Then, like the credit card, you just put this machine. Okay, put this machine. They can read, give you the data right away. Okay, all these individual components is already exist. Okay, like this machine, little bit different design. This machine already used in Africa. They can use this machine to detect CD4 numbers. Okay, using this machine, so they don't even need technical people there. Everybody can, to go there, take patients, drop of the blood, put it into this system and put into the machine right away. This information is going to the health institute all over the world. It depends on where you want to go. Okay, so the revolutionary changes here in the future. The centralized laboratory may be not necessary anymore. The physician can buy us this small device, put in their office for the private practice, or on the mobile clinic. They can get the result right away. So this has a tremendous impact on the elderly patient care, because you don't need take a blood, go to central laboratory anymore. you can do this study or testing on the spot. Sometimes you don't even need a technical people doing this. You know, any people just can do this. Also, another idea is, you know, for the homebound elderly, for people who have a difficulty to get out of the house, so they can spit, you know, their saliva, then put it into the freezer. Then somebody then just come in to collect these things and come back. So you don't need to have any invasive technical people there to collect their sample. So this is the dream of using saliva as diagnostic tool. It's going to happen in next 10 or 15 years. We're not talking about 100 years or 50 years. We're talking about in next 10 to 15 years. They already have a roadmap for you know, to put this product on the market. Right now, the pressure is on us, on biologists, to find the biomarkers. What kind of biomarkers do we need? So this is one exciting component, and we are part of the team, and we are glad, you know, we are part of the team. There's a lot of pressure on our side to produce. Other salivary gland research, like salivary gland disease, like I said, is like Sjogren's syndrome. The problem with Sjogren's syndrome is we don't even know how to make diagnosis yet. That's why NIH put a lot of money, you know, how do you make diagnosis of Sjogren? Right now, the so-called Sjogren's just by ruling out other diseases. You know, you don't have other things. We think that the patient has Sjogren's. Okay, so that's NIH push. We have research here doing this Sjogren research. Also, the radiation therapy induced salivary gland dysfunction is also is a problem, but unfortunately, in the United States, nobody can get funded because the study section doesn't think it is have a scientific merit or the proposal is good enough. So from my understanding, this category, United States probably only have a 1 or at most 2 grant support. Rest of the data come from European countries right now. Another thing is salivary gland tissue is an excellent tissue to study exocrine gland secretion. Okay, in collaboration with Dr. Katz, we look at the crosstalk between G coupled protein receptor and receptor protein kinases. We're going to discuss a little bit in the next few slides. And exocytosis, special gene expressions, other things. Our laboratory is not involved at this particular moment. Gene therapy is focused on at the NIH right now, intramural program. They put a lot of emphasis there. Then another thing NIH really push for is the tissue engineering and stem cell study for salivary gland tissue. So we have involved into two of this study. One funded by the VA, one funded by the NIH. So we take advantage of two. I just want to show you 2 animal models, what we are studying right now. We take advantage of 2 animal model. One animal model we use isopaternal induced salivary gland enlargement. Okay, this happens, you know, in after World War II. After World War II, when people go to concentration camp, they find all these people with starving have a huge salivary gland tissue. So their hypothesis is a stress-induced enlargement salivary gland. Okay, so they give animal isopaternal. At that time, they called stress hormone. You know, for certainly, you know, if you give isopaternal for less than a week, you'll see that usually the gland, this is the normal gland, become huge. Okay, but the third one, nobody knows why, and this enlargement is limited. It's not going to be a tumor. Okay, if you withdraw the medication, they slowly go back to normal. What is the mechanism to induce large? And it's one thing we are interested in. This is related to salivary gland proliferation and differentiation. I think that's very important for future salivary gland engineering. Another project we are involved, we try to ligate salivary gland ducts. Okay, the reason I show this picture is because my wife did it for me. So I have a so I want so I have to show another procedure we use. We try to ligate the rat's parotid duct. Then once you ligate them, the gland degenerates. See, from the arsenic, this is our arsenic cells with the secretory proteins, then degenerate into ductal-like system. Okay. Then after you release, the gland gradually grow back. That's why we are interested in the whole process. How these, what kind of signaling transduction system involved, how these cells go back to this stage and then come back. What kind of gene involved, what kind of mechanisms involved. So this is our focus in the laboratory right now using ISO, and we know both isopaternal induced salivary enlargement and degeneration of ductal ligation both involve beta-adrenergic receptor. Okay, conventionally beta-adrenergic receptor have their own distinct signaling pathway, nothing to do with this EGF receptor tyrosine kinase pathway. But in the past 10 years, people starting to look at this receptor pathway merge with this receptor pathway. That's what our laboratory focus right now. So we will study the mechanisms, how this isopaternal induced salivary gland enlargement, how this gland will recover regeneration, to specifically look at MAP kinase, mitogen activate protein kinase, which is linked to the EGF receptor. So that's our laboratory focus, and based on this research, we hope we can understand, the salivary gland proliferation, salivary gland tissue differentiation, so they can, using this information, we can do a tissue engineering in the long run. That's our dream. Another thing I just want is our recent study. We're going to finish up with Dr. Katz right now. Is also tell us what is evidence-based medicine. Pilocarpine, as you remember, we used clinically for probably longer than 20 years to treat xerostomia. The idea is this component is going to interact with muscular receptor, then induce a calcium mobilization followed by fluid secretion. Okay, that's the common consensus. Okay, but when we did one study, we used the salivary gland cells to stimulate pilocarpine. We don't see the increase of intracellular calcium at all. It's a surprise. Then you go back to literature. Everybody say this pilocarpine is going to stimulate the salivary flow because they are going to act with a muscular receptor, induce calcium mobilization, and blah blah blah. But if you look at the data, nobody ever show they can stimulate calcium mobilization. Okay, the best thing you can see is people show in here have a huge, they just show the 0.6, 0.5, then you show a little bit flex there. They say that's the calcium mobilization. That's the best you can see in the literature. So the thing is, pilocarpine not really cause a lot of calcium mobilization. It's not like we think. The carbocal is another parasympathetic mimetics. They do induce calcium mobilization. Okay, so that's so if they are not induced calcium mobilization, then how it works? Clinically, it works. You give a pilocarpine, although you have to give them more than 12 weeks before you see any result. So another hypothesis to look at other signaling pathway. So we look at muscarinic receptor and EGF receptor pathway. Then we use ERK, which is McKinney's path intermediates. We use this as a readout. So what we find is really surprising. We have a parallel copying, we have a coachable, both quote unquote is a parasympathetic mimetics. But they totally go through different pathways. Like a coachable, they go through a M1 and M3 receptor, muscarinic receptor. They have different subtypes. So they go through, let's say, we go through the muscarinic receptor. They induce calcium mobilization. They induce PKC activation. Then they activate ERK in here. Then the parallel copying goes through a totally different pathway. They go through, they also interact with muscarinic receptor, but they induce EGF receptor activation, then goes through this pathway to here. That's probably the reason you have to take, and ERK has been linked to cell proliferation and differentiation. So that's probably the reason you have to wait until 12 weeks in order to see the result. Okay. So this for me is really so-called evidence-based medicine. So what we see here, we say here is both parallel copying and coachable induce ERK activation in salivary gland cells, but they probably bind to different domains of the receptor and trigger different kind of signaling pathway. So we try to understand this in the future study. This study not only important for salivary gland research because I think also important for the other disease involves muscarinic receptor. So this we believe this research can link to lead to the other drug development for other diseases such as Alzheimer's and seizure problems. So this is my last slide. At today's environment, you cannot do everything alone. You need people to collaborate. On this side, most of the collaborator is from my laboratory. On this side, most of the collaborators from my clinical research. Michael Katz, Dr. Katz here, we closely collaborate, we work together and publish together, and it really is my pleasure to work with Dr. Katz. And we have a lot of good people to help us to present all this information I present to you. Michelle Saunders, we worked at Old South Sound, we continue collaborating, and this is my other collaborators in the clinic. Right now, the John McDavid is at UT Austin. He's the PI on our development of
nanochip thing.
Nanochip things. Yeah, he's our collaborator. Spencer Riding is our current clinical collaborator. So I stop here.
We want to ask questions. That'd be good. Can you turn on the light? Thanks. I actually have a question that I think will probably elucidate some things for the non-dental folks in the group, because you did so much early research on AIDS and saliva, and when they're looking at saliva now as a biomarker for AIDS, are they looking for a protein that gets generated as the body tries to fight it? What specifically are they looking for?
They are looking at the antibodies.
That's what I thought.
Yeah, they're
And just to
looking
make
at
it clear that this man right here is the one who proved that you can't catch AIDS through saliva back in the 80s when he was a research fellow at NIDCR. So he's got international renown.
That's why I got the title from. I think this Saliva is your friend. It's from the title from Washington Post. So when we first published, Saliva has not only it's not a vehicle to transmit HIV. Also, saliva contains component to suppress HIV infection. Okay, that I think that's the saliva is your friend is it's a title from Washington, either New York Times or Washington Post. It's not my invention. It's
Anybody
some
have any
editor-
other questions?
editor did.
Yeah, I've got one question. Any update on the idea that with pilocarpine used to stimulate salivary secretion during the course of radiation treatment to the head and neck, the idea that you may be
You get rid of all the granules, so
Yeah.
there's a less secondary irradiation. That's one practice they are doing right now.
Yeah.
But not 100%.
Yeah, although I've seen, I've heard of and seen some literature which has said that the use of pilocarpine is associated with more longer-term symptoms well after the course of radiation, more damage to the salivary gland. Any update in terms
So
of...
remember, when you treat with pilocarpine, first thing you have to do is you want to make sure the patient still have viable secretory component left. Okay, if you don't have secretory component left, doesn't matter how much pilocarpine you give to the patient, it's not going to have saliva content. So they're very important before you give patient pilocarpine. You want to make sure they still have a viable tissue there. That's critical. The one way we can do is we can stimulate stimulate the patient with citric acid or chewing or something to see if they have any saliva come out.
Yeah, I guess my question would be, you've got somebody with, good salivary function, getting some mild symptoms. The idea that if during the course, I guess the theory that I've heard is if you give the pilocarpine during the radiation,
That's one practice. Yeah.
that long term, you do something to the gland's ability to
Recover.
recover afterwards.
Right.
Is there any update in terms of where that's?
I think they still practice. The theory is they give pilocarpine. They hope they get rid of the granule. If you look at the acinar cells have a lot of secretory granules. So inside you have a lot of irons, calcium irons. So they try to push this iron out. So there's less secondary radiation. Okay. That's the theory behind it. Okay. I don't know about long term. People have used different ways to avoid glands right now, to irradiate, more targeted irradiation.
They need more studies. I mean, that's part of the problem that Chih-Ko referred to earlier, is that there are only a couple of studies being funded in the U.S. right now that are dealing with radiated folks. So they've got a ways to go before they can actually come out and say definitively that, yeah. Otherwise, it's more anecdotal than anything.
Thank you.
Any other questions? That was great. Thank you.